Good morning, ladies and gentlemen. Good morning. First of all, those of you who know me will know that I'm not Jenny Harries. My colleague Jenny is unfortunately not able to join us. She's our executive lead in Public Health England for the overseas territory, Caribbean overseas territory. So she's actively involved in the effort to support those communities. So her apologies. And so you've got me. I'm Rashmi Shukla. I'm a Regional Director in Public Health England for the Midlands and East of England region. And I'm delighted to be asked to introduce this session. I'm going to introduce David Taylor Robinson, who's a professor in public health and policy and a consultant in child public health at Alderhay Hospital, a very unique position, I would say, but very well qualified to speak to us about child health and child inequalities. Our conference theme has been around evidence, making a case for prevention, and working towards a fairer society. And I think David's presentation will bring all those components together in relation to child health. David will speak for roughly about 25 minutes, and then I will be asking John Middleton, the President of the Faculty of Public Health, to reflect on what he's heard. So can we welcome David to the conference.
Thank you very much. It's great to be here. Beyond the north-south health divide, what should we do about health inequalities? This is a seriously challenging question. And originally, Margaret Whitehead was due to come here to provide the answers. Margaret's been recovering from a long illness, so I've agreed to try and address this question with reference to our Due North report. Due North was commissioned by Public Health England, looking at the north-south divide in health. We produced the report at the end of 2014. It was chaired by Professor Dame Margaret Whitehead. Ben Barr, my colleague in Liverpool, took a leading role in pulling it together, and I led on the child health component of Due North. So today I'm going to outline how inequalities that we face are large and persistent. They have their origins in childhood. I'll look at some trends over time before turning to the Due North recommendations and focusing on some of the challenges that we face at the moment. And then finally, I'll turn to some evidence that shows that purposive strategies can make a difference. This is the north-south divide in life expectancy from the report. You can see the green fields of the south, the blood red of the north of England, such that a child born in our most advantaged areas, this is, for example, Kensington and Chelsea, compared to a baby girl born in some of our most disadvantaged areas, this is Kensington in Liverpool, around the corner from where I work, there's a gap of over 19 years in terms of healthy life expectancy. Now, we can say a number of things about these inequalities in health. First of all, there's nothing natural or predetermined about these differences. They're a consequence of how we structure society. Secondly, they're profoundly unjust. And thirdly, we can do something about these differences. The variation shows what's achievable within the UK. We outlined the inequalities that occur even within disadvantaged areas such as Liverpool. This shows life expectancy and how it plummets by 10 years on the basis of a short ride on a Merseyrail train. Where you live can kill you. This is the latest data on life expectancy in men from the poorest tenth of areas to the most disadvantaged tenth of areas, showing the finely graded relationship. This shows healthy life expectancy in men. The axis has changed. There's almost a gap of 20 years now in terms of healthy life expectancy. When this data came out at the time of Due North, the Telegraph pointed out that life prospects in some of our poorest areas are worse than the average in Rwanda. And if you draw a line at age 60, you can see that 3/10 of the population cannot expect to live to age 60 in good health. This is for men. Now, this is not just unfair, it's also profoundly costly. It's one of the reasons why, in the 5-year forward view, we heard about the need for a radical upgrade in prevention and public health. These inequalities have also been persistent over time. This is an analysis from Ian Buchan, Tim Duran in Manchester and York, looking at the north-south divide over a 50-year period up to 2015. The red line shows crude mortality in the north, the blue line, crude mortality in the south over time. And the authors calculate 1.2 million excess deaths in the north of England. How would Michael Marmot put it? This is social injustice killing on a grand scale. What causes these differences? Well, we're very clear in the Due North report that the drivers of the north-south divide are the same as the drivers of health inequalities anywhere else. It's just simply the severity of those causes in the north are greater. They're due to inequalities in the distribution of the social determinants of health. And to be clear, we say in the report, they're due to differences in poverty, power, resources for health, differences in exposure to health-damaging environments, differences in access to protective factors and conditions, especially those that generate the best start in life. Now, a focus on children is nothing new. Margaret Whitehead always points out that in 1980, when the Black Report was published, that was the central focus. It was about families and children and the material conditions in which children grow up. And of course, the Marmot Report made giving every child the best start in life its highest policy recommendation. So let's turn to some inequalities in child health. This plot shows, first of all, we don't have particularly good child health outcomes in the UK compared to European comparators. This is actually OECD countries, rich countries. It shows under 5 mortality plotted against relative child poverty. The UK in red has the highest under 5 mortality in Western Europe, double that of Sweden, such that an extra 5 children die per day, above and beyond the rates that we would have if we had those in Sweden. And in Due North, we make it clear that social spending on kids is associated with better population health, even for a metric like infant mortality. Now let me show you the distribution of some child health outcomes over the life course for kids in England. This is our analysis of infant mortality plotted against child poverty for English local authorities. More infants die in our most disadvantaged areas. This is early child development at the time the Due North report came out. This is the proportion of children ready for school plotted against child poverty. There's a clear relationship. The other thing that you notice is that there's huge scope to improve the developmental potential of children in this country at a population level, to shift the distribution. This is obesity. This is obesity and overweight, again at local authority level, plotted against child poverty. In our most disadvantaged areas, in Liverpool where I work, 40% of kids are obese or overweight by the time they're 10 years old. And we know that these conditions cast a long shadow in terms of children's health subsequently and life chances, such that we arrive at an understanding of health trajectories informed by the life course perspective. You could have anything here on the y-axis almost: cardiovascular health, respiratory function, mental well-being. The childhood period is a period of investment in health. It plateaus. The economists call it investing in your stock of health. And the patterning is determined by the risks we're exposed to, the health protective factors we're exposed to. This is critical for the patterning of child health outcomes, but it's also critical in terms of the age of onset of a whole range of adult chronic conditions. So we need to link the life course together when we're thinking about prevention, because we know that a whole range of expensive societal, health and social problems have their origins in the childhood period. I just want to show you some trends over time. This is infant mortality in EU countries in 1960. We're not far from the Nordic countries. Let's move through time, 70, 80, 2000, 2010, 2014. On the verge of leaving the EU, we have one of the highest infant mortality rates in the EU. And this is before the latest data is added in. This came out a few months ago from ONS, showing that infant mortality has risen in England and Wales for the first time in a 10-year period. We looked at the data by socioeconomic status, by parental social class. You see declining infant mortality in the most advantaged groups, a kick up in the most disadvantaged. The Royal College of Paediatrics and Child Health produced this helpful report a few months ago, outlining stark inequalities in child health, some of them growing. For example, obesity, again, one of the big challenges we face. This is proportion of kids who are obese in the most disadvantaged quintile by age 10. This is the least deprived. There's increasing trend, decreasing trend, increasing inequalities in childhood obesity. The Department of Health annual report reported on a number of indicators of inequalities, showing widening of the point estimates since 2010. And another important piece of data is to consider what's going on with the plateauing of life expectancy that we've seen across the country, and to think about the implications of this for the health inequalities narrative. So I'm going to turn to the Due North recommendations with particular reference to children. So in Due North, we talked about things that agencies in the North could do together, things that the NHS could do, Public Health England. And they were in a number of areas. So we focused on the need to tackle poverty and economic inequality, a focus on children, sharing power and resources to increase public influence over decision making. And let me turn to some of the recommendations for children. We suggested that agencies in the North can come together to increase the proportion of early years spend, focus on access to high quality early years education and childcare, maintain and protect neighbourhood support for children, focused on the children's centres, develop and sign up to a rights-based approach to protect the rights of children to the best possible health, and collect better data on kids across the life course so we can track inequalities. In terms of central government, there was a need to reduce child poverty. We know how to do this through measures advocated by the Child Poverty Commission. Increase the spend incrementally in the early years period. Embed a rights-based approach to child health across government departments. And focus on health in all policies and cumulative impact assessment of changes to systems that influence children, including changes to the welfare system. The NHS has a key role in terms of how it allocates its resources. These can be focused to reduce health inequalities, as I'll show you. CCGs can pool resources at local area level in order to protect services for children. And the NHS can encourage the provision of more holistic primary care services that can help lift children, especially those with chronic illnesses, out of poverty. We suggested that Public Health England can take a key role in advocacy for children, in terms of putting them at the centre of policy making, help to establish cross-departmental systems of health impact assessment, and support cumulative impact assessment of changes to the welfare system and of the cuts to local services, and help local authorities to develop risk mitigation strategies. We've seen a number of challenges, especially with regards to children. We wrote in the BMJ about the gains of the past being undone. We're seeing rising levels of child poverty. Child poverty has increased year on year over the last 3 years. This is the latest data over time, showing an increasing trend in poverty after housing costs, such that 1 in 3 children now live in relative poverty in our country. We know that this is the result of certain policies. The Institute for Fiscal Studies have produced numerous reports showing that families with children have borne the brunt of some of the changes to the system. This is their analysis of the impact of tax and benefit reform from the poorest families to the richest. The grey line at the bottom, families with children. The poorest kids have seen the biggest changes to their household income. This is what's coming as universal credit is phased in. Big impact. This has happened at the same time as the cuts to local authority budgets that support local action on the social determinants of health. This was our analysis when the data first came out, showing the budget cut against deprivation score for local authorities. That was Liverpool at the time, up at the top left, top right, the most disadvantaged local authority, biggest cut to its budget, systematically greater cuts in the north compared to the south. And this is what actually happened. This looks at the cut per head of local authority resident at local authority level against premature mortality. The sickest areas have seen the biggest cuts to their budgets. This is Yoko Ono opening the Children's Centre around the corner from where I live. It's the school that John Lennon went to. It was a £1 million investment, and it's been incredibly challenging working in child public health in the city to sustain investment for prevention for children in the face of these challenges. And indeed, many children's centres, as we know, have shut down in the most disadvantaged areas. These were the systems set up to improve social mobility in children and reduce inequalities. We highlighted concern over the rise of food bank use in the UK and went on to show the drivers of the opening of food banks at local area level. This is areas that had food banks in 2009. This is 2013. This was driven by changes to welfare support for families, particularly the practice of benefit sanctioning. Homelessness affecting children has gone up. And again, we showed in this analysis that it's driven by changes to social support for families. Difficult times for families living in the most disadvantaged areas. In the face of these challenges in Liverpool, drawing upon the Due North recommendations, we organised a children's summit to assert the rights of children to better health, to bring together everybody involved in the system, develop a vision for the city, and to focus on what we can do with the resource we have to protect services for kids. Also drawing on Due North, the city undertook a unique cumulative impact assessment of the changes to the welfare system in order to develop a risk mitigation strategy. Now, one of the solutions to child poverty was to suggest that it needs to be redefined so as not to be about family income, but more about parental behaviour, family structure. We disagreed with this, as did many people. And led by the Faculty of Public Health, we contributed to this report. This is an example of health in all policies, again, as advocated in Due North. So we presented data, some of which I've shown to you, on the impact of poverty on child health and the impact of welfare reform. We showed this analysis. This shows the proportion of children with socio-emotional behaviour problems, borderline socio-emotional behaviour problems, against their cumulative exposure to poverty in the nationally representative UK Millennium Cohort Study, showing a clear dose-response relationship. We went on to show the impact of families moving into poverty on child mental health and maternal mental health, showing that family transition into poverty, everything else held equal, significantly impacts children's risk of mental health problems, and it's partially mediated by an impact on mum's mental health. Obviously, the early origins of child mental health, serious public health concern at the moment. We argued in the BMJ that some of these policies represent a failure to protect the rights of children. Where's the advocacy been for kids whilst some of these policies have been implemented? The Lancet covering the report, talked about welfare reform being disastrous for some of the poorest children. And although the Child Poverty Act was repealed, the Lords voted to maintain the income-based measures of child poverty. evidence can make a difference to policies. I'm now going to show that there is evidence that purposive policies can also impact on health inequalities. This is an analysis by Margaret Whitehead and Ben Barr, Claire Bamborough, that came out a couple of years ago, looking at the impact of the NHS resource allocation policy on health inequalities. This was a strategy introduced in 1999 to shift more resource into disadvantaged areas. It's been described as an experiment in proportional universalism. This is what happened. You can see increasing resource to the more disadvantaged areas in red over time. And for example, in Liverpool, how was this spent? Well, it was spent on tackling the inverse care law in terms of access to services, a focus on proportional universalism in prevention in terms of smoking cessation, blood pressure control, a focus on the wider determinants of health, so healthy homes programs, setting up the children's centres, and harnessing the NHS resource locally to stimulate employment. And this is what happened. The analysis, this shows a narrowing of the gap in mortality amenable to healthcare, linked to this policy, showing that if you invest in more disadvantaged areas, it can reduce inequalities. This analysis came out a few weeks ago, again from Ben Barr and Margaret Whitehead, looking again at the impact of the English health inequality strategy implemented from 1997 up to 2010. As we all know, this involved a whole raft of policies and interventions, some of them national, many of them focused at local area level, including the establishment of Sure Start. The strategy failed to hit its own targets. But this analysis shows changes in trends in inequalities before, during, and after the implementation of the strategy. This shows life expectancy against year for males. If you just look at the red lines there, they're absolute and relative inequalities, subtly increasing prior to the strategy, decreasing during, and then a turnaround since 2010, showing that we need to take another look at what happened over this period. The authors suggest there's potential to reduce inequalities through purposive strategies. So I'm going to draw to a close now. What do we do about health inequalities? I hope I've outlined the central need to focus on the social conditions in which children grow up. It's absolutely baffling to me that we allow an exposure as toxic as child poverty to wash over such a large proportion of the children in this country. This is a modifiable exposure. I've outlined some of the recommendations in the Due North report and also those that Public Health England can take forward. And the central challenge to practitioners is to advocate for policies and practices that are going to improve the developmental trajectories of children, especially those living in disadvantaged conditions, as a way to improve their health and also as a way to reduce inequalities over the life course. Thank you very much.
Thank you, David, for a very thought-provoking and stimulating presentation. So no doubt John will have a number of comments to reflect on.
Thank you. And thank you, David. Your clarity and your thoroughness in answering all the questions that I think we have is exemplary. And thank you to your colleagues as well, Ben Barr and Margaret Whitehead. The thing that surprises me is that any of this surprises us anymore. In our training, we know the Boer War recruits were unfit to fight because a third of them were so poor and so ill that they couldn't pass the test. The slide I showed yesterday, Gro Harlem Brundtland, who attributed the tiger economy's growth in Southeast Asia to improvements in health. An 18-year life expectancy improvement preceded the industrial power of the Southeast Asians. And the Russian or the Soviet collapse of the Soviet Union propelled millions of deaths and a much decreased life expectancy. So why are we surprised by this? Black, what we learned from the Aitchison report in '97, pretty much exactly the same as Marmot in 2008 and then 2010. So we have plenty of evidence. I think what David and his colleagues have done is sharpen that up for us. And I think what was a stark finding for me in David's comments really is the how we are failing our children, particularly the under 5 mortality and the other report on why children die. The child poverty in this country is appalling and unacceptable, and I think we do have to pick this up as an issue of health and rights. I was also pleased to see that role of the NHS, that in fact in the first wave of STPs, less than half spoke about children at all, and we have to redress that. These are major lifelong policy and opportunities that we're missing, and it is a time bomb for the health of the population by 2040. So finally, I was told that I had to, in my press training, I had to be able to summarise everything in 15 seconds, which might be about 140 characters, I don't know. But basically, poor people die younger. Poor people get poor services. Make them poorer, and they will die even younger. And cut public services, and they will be the ones who get the poorest of those services. Or in short, as the placard says, austerity kills.
Thank you, John. So we do have time for one question, because both our speakers have been very, very good to keeping to time. Is there any burning question anybody wants to raise? Okay. Can we have a microphone? Paul in the second row, just down here. Oh. Paul, you might want to shout. Just shout the question and I'll repeat it.
Okay, can I just say thanks very much to David, and I mean this is a huge challenge still, and I think my point is for everyone in this room really, we need to keep thinking about how we keep framing and reframing this so this doesn't become old news, building on your point, John, and I think the opportunities we've got here are around devolution, elected mayors. We've got accountable care organisations in the NHS. We've got a whole, I think, Grenfell and the messages, the painful messages in Grenfell. We've got a government, I think, that is saying now we want to make this a fair and just society, and a time where I think we're looking at what sort of country we are as we go into Brexit conversation. So I think the point is, let's keep this really alive. Keep the language alive and use the new opportunities we've got. And there will be others as well. The whole movement of asset-based community development, I think, has really changed over the last 2 or 3 years. It's become quite embedded in many areas. So it's not just needs, it's actually building on assets. And I think my point is, let's just keep, as a community, we need to keep framing and reframing this whole.
Okay. So for those colleagues who might not have heard what Professor Paul Johnston just said, basically about continue to reframe the issues that David's talked about very eloquently. We have the opportunities through devolution with elected mayors and also the STPs and accountable care systems and organisations. So as the public health community, let's keep advocating for children's health and giving children the best start in life. Can you join me in thanking both our speakers? And the next sessions will start in 10 minutes, so do please make sure that you get there on time, because they will start on time. Thank you very much.
I didn't say rural.